What's up, everybody jumping in? Happy Friday. Hope everybody's doing well. We're on YouTube and Instagram. So happy Friday, everybody. Hope you guys have had a good week. Get into this Q&A here. Whatever you guys want to talk about, fire away in the comments section. Again, on YouTube, go ahead and submit anything. Welcome in. Waving back at everybody. Like I said, today's our Friday performance Q&A. So anything performance fitness based, I'm happy to answer. One of the things that we get all the time, the questions that we get all the time is, I'm having pain here. My answer to that is going to be go see somebody. So I can't address that via Instagram Live or YouTube. But like I said, anything that's come to your mind over the last week or so, feel free to ask. So starting off with a good one. Nice question. Let's see. NTA Fit. Have a client with runner's knee. She runs track. What's good for her? I know it's going to sound like a broken record for some, but go into our assessment. Right, that runner's knee is going to be obviously an overuse injury or pathology for that person, and if they are a track athlete. And that's their sport that they play, let's say for a scholarship or whatever, there's certainly a better solution to say, hey, just stop running track. That's not realistic. So go into that assessment. You're more than likely going to find some sort of dysfunctions that you can address and incorporate a corrective approach to that. So I'm going to assume there's going to be some lower extremity dysfunction, so feet flat and feet turn out. More than likely, that's going to be there. She may also have some lumbo-pelvic hip, so maybe knees. That person may have knees fall in, knees fall out, maybe even an asymmetrical shift if she's having knee pain on one side and not the other. So that might be something to take into consideration. There's various techniques, so I would recommend your release techniques. But not just releasing everything. Release the stuff that you've identified in that assessment as overactive, right? So do those release techniques. You can play around with some self-administered joint mobilizations. There's actually some courses up and a course that was just posted about some of the mobilization side of things and the effects that they can have. If you don't feel comfortable with those self-administered mobilizations, or if they cause more discomfort or they just don't feel good for that person, you can omit it, right? Don't just try and force it. But try that, check those out, and then do some maybe lengthening techniques for some muscles, particularly like gastroc, maybe even fibularis, so you can kind of get both of those muscles in a calf stretch. And then activations, right? And I'm going to assume it's going to be probably some tibialis anterior, posterior, but also glute. I think you're going to run into some glute max, glute med. Really need some work, and always throw in TBA. So that would be my best starting point. Obviously, I don't know that person, but hopefully that gives you just at least a start of, okay, let's check out what's going on at the ankle, what's going on at the hip, right? Even check out upper body, but maybe for this person, it's not as big of a factor. But let's see what's going on at that ankle and lumbo-pelvic hip, and see if we can get to the bottom of that and at least get them out of that discomfort on a regular basis. Making sure that you're doing the corrective interventions with you, but also give them some homework, give them some things to do on their own that's going to help with that carryover that you might find, right? So hopefully that gets you started. If you have more about that, feel free to throw that in there. I can expand on that if you want. But like I said, try that. Most of the track athletes that I've worked with in the past do have some significant lower extremity dysfunction. So lots of tibialis anterior work, lots of tibialis posterior work, taking out that overactive gastroc. And then I've also found rec fem, TFL overactivity, and glute max, glute med. As strong and as powerful as they are, glute max, glute med can always use a little bit extra. So hopefully that's helpful. I'm assuming with all the hearts that are thrown at me, I'll take that as a good answer. I have a client with a hip hike. What would you recommend to improve that? All right, so that hip hike, I'm going to consider as they do that squat, we're going to consider that asymmetrical weight shift. I think that's your best approach. And when you see that asymmetrical weight shift, break down those signs. There's a great video on the website that kind of breaks that down for you. It makes it really easy to address, right? Instead of going through this laundry list of muscles, some on this side, some on that side, it makes it really simple and easy to follow to address that, and then reassess and see if that made it any better, right? So what you're seeing could be a hip hike, or it could be that shift, or it could be some other weird movements that's happening there. And kind of go from there. So I think that would be my first approach. And obviously, if there's causing some significant pain or anything along those lines, and it's outside your scope or you don't feel comfortable with, refer out, because there might be something else there. But treat it as that asymmetrical weight shift. I think that'll serve you better than trying to figure out that big laundry list of hip hike stuff. Plus, if you're not a massage therapist, there may be some, or manual therapist, there may be some things in there that you really can't get to, or you can't address, or you can't address well. So, try that. Let's see what else we got on here. So my YouTube crew, go ahead and you can type some questions in there. I got one the other day, but don't have one now. Ann, waving back at you, my dedicated Friday Instagrammer. Happy Friday. Your elbow always locks. It should, right? Does lock. It goes into extension. If you're talking about excessive, or if you go into some hypermobility there, that can be a problem. I would suggest, especially if you have pain, go see somebody. That hypermobility is a big issue as well. I know we talked a lot about hypermobility being just as potentially just as bad as somebody who has hypomobility, right? So somebody who's restricted in that range of motion, and versus somebody who's got too much range of motion. Both ends of the spectrum can be bad. Open chain or closed chain exercises for meniscus repair? Yes. How about that? I'm not necessarily going to, obviously it depends a whole lot on what their issue was, what their surgery was, where we're at with that in that kind of rehab piece. But classically, what you're taught, or what you're kind of looking at, is those closed chain exercises tend to be a little bit easier. And the open chain exercises tend to be a little bit more difficult kind of later on in their rehab. But that, again, is going to be very dependent upon the person and what their therapist or their physical therapist or orthopedic says, or their surgeon says. So that one's a bit tricky. Obviously, I'm not a huge fan of leg extensions with somebody who's got some sort of knee repair, not until like way past their kind of initial rehab setting. And that would be that open chain exercise. So I would kind of avoid some of those. I definitely wouldn't add hamstring work in there, so leg curls in there. I'm going to focus more so on that glute work and TVA work, and whatever way I can do that, that's comfortable for them. So again, it's going to be very dependent upon where we are at in their rehab piece. Obviously, listen to their PT, listen to their orthopedic, get those directions. And then if you're a trainer, you can follow some of those guidelines and then do the things that like I said, glute work, TVA work, because all that stuff's is going to have been shut down with that repair, with that surgery. So hopefully that's somewhat helpful. I got my Facebook or my YouTube crew. Autumn, 16-year-old hockey player with shin splints. Again, check out that assessment. I'm going to probably guarantee that they have lower extremity and lumbopelvic hip complex dysfunction, as all athletes do, and especially young athletes. They're kind of still developing. So I would say kind of along that same line, tibialis anterior work, some glute work, some TVA work, maybe some vastus medialis work. Again, it's going to be very dependent upon what you see in that assessment. But I can probably again be fairly confident that in that hockey player, just the nature of that sport and the pushing off and the movements there in those skates, and that locking of the boot, they're going to have some dorsiflexion restrictions. So I'm going to say lots of lower extremity dysfunction for that person. So I would focus on some things like that. Gastroc release, fibularis release, ankle mobilizations or ankle self-administered joint mobilizations with a band. They work really well. And then maybe some calf stretches and do some tibialis anterior, tibialis posterior activation and have him do his homework or her homework, right? So I would start there. Great questions, guys. Patrick, again, what is the deal with the coaches having their athletes warm up their shoulders with a PVC pipe? I don't know. I don't know where that came from. I don't know why that started. I don't know what that does exactly. I'm more so in the field of, okay, I know that if we're going to do upper body day, for instance, I'm assuming that's why they're warming up with a PVC pipe. I would be better served and my outcomes would be better if I focus on releasing the overactive tissues. And especially even if you're training in a group, you have common muscles that tend to have this overactive behavior. So I would go release lats, release levator, release rhomboids, right? As a group, everybody gets a tennis ball and goes up against the wall or on the floor, right? Then go into maybe a child's pose if you're in a big group, right? Do a child's pose, stretch real quick, just kind of get a little bit of length in there. And then let's do some posterior rotator cuff activation, deep cervical flexor activation if you can, posterior rotator cuff activation, serratus anterior activation, lower mid-trap activation. Like those would be better served. And that's going to get you that full range as you do those movements. That would be better than just bringing a bar behind your head back and forth 1,000 times. So I don't know what the deal is. I'm assuming you don't do that. So, I think you can have a better approach to that and be better serving your client or patient base, right? So, like I said, upper body dysfunction, we see a lot more of it. I just did a webinar on cervical dysfunction on Wednesday for our members. So we're seeing a lot of that. We have a lot of that. So I think that's something that we can certainly address and approach and see some benefits to, right? So cool. No, I totally don't. I like it. Cool. Good questions, guys. Great to start off on these. I like it. Another great question by wab.blp. Why do you do self-administered release or release techniques before doing joint mobilizations? So we do the release to turn down that overactive muscle. So we want to do that prior to those joint mobs to help. If you have to try and do a joint mobilization, if you're familiar with those, right? We're trying to increase that intra-articular space. Well, if you have an overactive muscle kind of pulling one direction, you're never going to get that space because every time that you kind of get a little bit of a range going, that overactive muscle is going to pull it kind of right back. Very simple, archaic example, but we want to release those muscles that have too much tension in them or have this propensity to be overactive. We want to release those muscles so now there's no pressure, quote unquote, pressure or tension on that joint. So now when we go into our joint mobilizations, we get a little bit more of a free flowing joint piece there. So hopefully that makes sense. And then after that, we go into our stretches, right? And we want to do that after mobilizations. We want to do our lengthening or stretching techniques after mobilizations, because again, same thing. If I have this restricted range and I try and go into a stretch, I'm not nearly going to stretch as much as I would if I if I increase some of that articular space, I now can get into a little bit deeper of a stretch. So hopefully that kind of makes sense why there's that series there of release, mobilize, lengthen, and then address the opposite side of activations and integrations from there. So great questions. This is awesome. Let's see. How does the membership work? You pay yearly for keeping your certificate valid. Adrian, great question. So the Brook Bush Institute works almost like Netflix, right? So you have a monthly fee or a yearly fee. We have those options. You can pay monthly or you can pay yearly. And it's one of those things where once you pay, you have access to everything on the website: videos, certifications, courses, everything. Audio, voiceover, all that stuff is all for you. Just like Netflix, where you pay for Netflix and you can watch whatever you want. Whatever documentary or mockumentary or movie or show that you want, you have access to. And that's kind of where we're at. We give you pick whatever you think is most appropriate for your profession or what you're looking to learn. Now, with the certification side of things, so we have the CPT, we have the HMS, the Human Movement Specialist, and then the Integrated Manual Therapist certification. Those certifications are sort of like, they're yours, right? You take X amount of courses, and once you get those courses, or once you've fulfilled that course requirement or that credit requirement, you're good. That's yours. Put it on the wall, put it on a plaque, put it wherever, send us a picture, and you're good. That's yours. Now, you can let your membership expire and you'll still have that certification. Or what you can do is stay a member if you want, and any course that you take will push that expiration date of your certification back, because you're still doing all those courses act as continuing education. So you're still doing continuing education, and that pushes that expiration date of that certification back, X amount of time. So that's kind of how that works. So you don't have to necessarily pay to keep it valid. You still have it, and it'll be valid for 2 years, like most certifications. But any extra courses that you take is just going to push that expiration date back further. So you don't have to like recertify, or you don't have to pay more to recertify. You can just stay a member and take a course here and there, and you'll be good. And again, like I said, you can cancel anytime and you can jump back in anytime. So all of your kind of records and info kind of stays. So I don't know. Hopefully that's helpful. Hopefully that works and makes sense. All the courses are continuing education credits for every other thing that's out there, whether certification or credential. So I don't know what your scope of practice is, but it's usually covered with CEUs. So hopefully that is helpful. Let's see what else I get. Cool. I'm glad that was helpful. NTA_fit. I like it. I'm glad that was good. Let's see. For true lower leg dysfunction, yeah. So for somebody who's got, let's say, a leg length discrepancy, and that's a diagnosed leg, not just somebody going, oh, one leg's longer than the other. It's a diagnosed leg length discrepancy. There may be some things that you would need to kind of give them. So the insoles or whatever it is that you, if you're a PT or your doctor or orthopedic, recommends. However, just because you have that leg length discrepancy, or a conversation that we have all the time, is just because you have, let's say, somebody with scoliosis, and they have that shift in their overhead squat, or if they have that, lower leg dysfunction, one leg or one foot more than the other, you still treat the sign. You're never going to fix it. You're never going to correct the leg length discrepancy. You're never going to fix scoliosis or anything along those lines, but treat the sign. And I can probably assure you that they're going to feel better, right? Doing whatever it is, that they're doing. Whether that's walking or running or playing a sport or training or just therapy in general. If you treat the signs and not the diagnosis, you're going to end up with better outcomes. So hopefully that's helpful, Dr. Azar. I think I'm saying that right. But do the best you can, right? Obviously, if you need to throw an insole in there, and that's what they need to help kind of keep everything else in alignment, then great, that's fine. But still treat with the signs that you see, and I think you'll have better outcomes that way. On Nasia, I'm sorry if I mispronounce your name, but there are no textbooks, so everything's virtual. Get with the times. No, yeah, we did everything virtually, or online on the website, just to kind of make it easier. Textbooks are expensive to not only buy but also to make. So we want to try and keep that cost of entry very low for people. So I don't foresee us ever having textbooks. Plus, there's a ton of information on the website, so it could probably fill, I don't know, 4 or 5 textbooks with stuff. So I know, some people love having the textbook in front of them, but unfortunately, we just don't have that for you. You can print everything out if you want. Go to FedEx, and I'm sure they'll be glad to take your money to print all that stuff out. Marvin, I think I answered your question earlier for open and closed chain, so I'm going to skip that. Cool. Client with forearm lateral epicondyle pain and elbow tenderness. Go see a PT or orthopedic. One thing that I really want to kind of hone in on: do your assessment and address what you see. Sometimes what we find, and just in general, what you may find is some scapular instability, some scapular dysfunction, some shoulder dysfunction, some elbow, that when they do their overhead squat, that elbow's like bent, they can't get it straight. So that can give you some information. But if all that stuff you've tried and it's not working, and they're still having some issue, refer out, go see somebody, and maybe see a few people that you trust. Again, think about what they're doing. That's going to certainly have a important component to it. If they're stuck at a desk all day, kind of typing away for 8 hours in a really bad, tough position, then that's probably not going to solve anything either. So maybe have them, do some things on their own. So, but that one's tricky, right? So it could be from a lot of different places. I was actually just talking with the doctor over the last weekend. Treated somebody who had epicondylitis and went to a bunch of different doctors, and addressed just the elbow, injections. That was their answer, and he just worked on scapular stuff, and things started to improve. Right, so it could be from a lot of places. It's the same thing with knee pain, right? We talk about this all the time. Don't just treat the pain, treat the dysfunction that you see. All the time that we see knee pain, it may be coming from the hip or the ankle. So keep that in mind as well. Hopefully that's somewhat helpful. But again, I tend to refer out to your physical therapists or orthopedic surgeons. Tailbone pain, go see someone, right? I can't give you too much on Instagram without seeing an assessment there. Let's see, hugging the fly, twisted upper body from lower body, left shoulder lifts. Bad alignment, yeah, sure. Again, it's tough when you're trying to kind of look at yourself and assess yourself. Plus, you kind of know what your compensations are, so you may try to hide it somewhere. So what I would suggest is partner up with somebody who you trust, somebody who's well versed in assessing and let's call it, giving interventions or prescribing interventions, or if you know a physical therapist or a chiropractor, somebody that you really trust. Have them do that assessment. Have them identify what they see, and then see if you can come up with some release techniques and mobilizations and lengthening techniques and activations for those dysfunctions, right? I'm assuming you have an asymmetrical weight shift. Check out the video. If you haven't seen it, check out the video. Maybe that can answer some of your problems, because that asymmetrical weight shift could come from a whole bunch of segments. It could come from ankles or lumbopelvic, hip, or upper body. So things like that, see if you can deal with and address, right? How do you treat somebody who doesn't want to do their homework? You kick them out. No. Yeah, so you're always going to run into the non-compliance side of things. That's just it. I mean, one of the things that you can probably say is, listen, you can pay me this lots and lots of money every time you see me, but if you don't do this couple things. You don't have to give them a laundry list. That's the other big thing, is don't give them 16 different things to do. Give them like 2 things. You can pay me all this money, and if you don't do these 2 things, you're just going to keep paying me all this money. That's fine, right? I'll take it, but you're never going to see improvement. If you really want to get better, you have to put in the effort, put in the work, and do it on your own. And then you don't have to pay me as much, which leaves you more money to do other fun things. So I think when you throw the money, the skin in the game side of things, maybe they get a little bit more serious with it. But again, you're always going to run into non-compliance. People that just want that one quick fix, that one thing, that one whatever to get them out of their issues. And unfortunately, I don't think those things exist as much as people would like. So it's just like fitness, right? Just like training. I want the 6-pack, so I'm going to do these crunches and hanging leg raises that I saw on Instagram real quick, and by tonight I'll have a 6-pack, right? I want that perfect workout, that perfect supplement, that perfect whatever, that one thing I need to do, and it's just not the case. So you do what you can, and just keep in mind that you can't help everyone, right? That goes for everybody: trainers, massage therapists, chiros, PT, everybody in there. All right, let's see, Marvin, that meniscus person, you got that crepitus in there. You do, with the movements that you do everything with as large range of motion as you can without pain or dysfunction, right? Go from there. So whether maybe it's not full weight bearing, maybe it's not a full squat, maybe it's not a full movement, right? You do what you can with the greatest range of motion that you can without pain or dysfunction. Go from there, right? And again, remember, when it comes to rehab and when it comes to surgeries and injuries, it takes time. It takes time to heal and recover. So, keep that in mind. Cool. Thank you. Adonis, if you have a suspicion that the muscle is short but the client doesn't feel a stretch, could be a couple things. So number one, don't go by people's feelings, right? Because people feel their hamstrings are tight all the time, and most of the time they're not. So don't worry about necessarily their feelings of it. What you should think about is, am I positioning this person in the best possible position to get the best stretch possible? So, for example, you threw TFL in there. The TFL stretch that we have is that kneeling hip flexor stretch. So you're just in a half kneel position. Take that leg that's down and turn it in a little bit. That'll create a little external rotation, and get a glute squeeze and an ab squeeze and hold it for a few seconds, and you should find that they get a little bit of a stretch going in that TFL. But also, we have to keep in mind that they may not feel that, and that's okay. You just get them in that position, you do that intervention, and go from there, and then reassess and see if it made a difference. That's how you know you're onto something. Same thing for piriformis. Piriformis is a tricky muscle to stretch. I tend not to stretch piriformis unless somebody has this knee bow out or asymmetrical weight shift sign. And also, piriformis stretching can irritate some things, so just be careful with that one. That figure 4 stretch is more like a posterior hip capsule stretch, not necessarily piriformis. So you get a little funky in there with piriformis. So just be careful or cautious with that one. That might flare people up. Same with your trap, your levator and trap stretches, your neck stretches. I tend not to use those a whole lot. What I would suggest, though, instead is doing those release techniques, because with those release techniques, you're also going to get a little bit of extra length there with that pressure of the ball, and those dynamic release techniques work as well. So I would try that. Try that stretch. If they don't feel it, make sure you're positioning them the right way, as best of a position they can be in, and then kind of go from there. Nasha, the sciatic and SI pain side of things for assessment, kind of outside of scope here for this conversation. Check out, there's some courses on the website with SI dysfunction and some assessments and some pieces there that I would kind of send you to if you need more of that. And Ann, you're going to be my last one. If one moves, if somebody shifts weight to the right, that is so when you're looking at that shift, if you have that person shift and their hips or their weight shifts off to the right side, that is the side of the shift. Yep. So the right side would be the side of the shift. So hopefully that's helpful when you're looking at that. So like I said, you should see kind of that hip go straight up and down. But if they're squatting and that hip goes off to the right, that's a shift to the right. That's the side of the shift. So, guys, happy Friday. Great questions. I appreciate you all. My YouTube crew, phenomenal. Welcome. I'll see you guys next Friday. This was awesome. Great questions. Keep them coming. Have a great weekend. Go do great things. Go be awesome. Happy Friday. Enjoy the weekend. I'll see you guys next week.